Welcome to my talk on surgery for undergraduates. Today's talk is on obstructive jaundice. Obstructive jaundice is a very common condition that we see in our patients today, and it is also a very important topic in surgery for undergraduates. I shall try to highlight and give an overview of obstructive jaundice for medical undergraduates. What is obstructive jaundice? Obstructive jaundice is a condition in which there is blockage of the flow of bile out of the liver. This results in redirection or reflux of the excess bile and its products into the blood, and the bile excretion from the body is incomplete. Jaundice is a yellow coloration of the skin, mucous membrane or eyes. The yellow coloring comes from the bilirubin, a product of the breakdown of the RBC in the blood. Therefore, obstruction of the bile ducts leads to accumulation of the bile, especially in the liver, which therefore refluxes into the blood and is carried to the rest of the body, where the staining of the tissues occurs. Now let's go through the bilirubin metabolism and to understand what happens when the bile ducts are blocked. In the prehepatic phase, unconjugated bilirubin is formed from the hemolysis of RBC, mainly in the spleen. This unconjugated bilirubin goes into the liver where it is conjugated, and this is the intrahepatic phase. The conjugated bilirubin is subsequently excreted into the bile ducts, which carry it to the small intestine. And in the small intestine, it is converted to urobilinogen and stercobilinogen, which gives the normal brown color of the stools. Now let's see what happens when the bile ducts are obstructed. When the bile ducts are obstructed, the drainage or the flow of bilirubin into the intestine is blocked. As a result, there is lack of conjugated bilirubin in the intestine. Thereby, stercobilinogen is not produced. As a result of this blockage, the next stage is there is an increased concentration of backflow, and pressure increases due to the congestion of the liver with conjugated bilirubin, which then diffuse back into the circulatory system. And the high level of conjugated bilirubin in the circulation results in the staining of the various tissues by the bilirubin. And so the patient becomes jaundice due to hyperbilirubinemia. Some of the urobilinogen in the blood is then excreted by the kidneys into the urine, which gives the urine a dark color, and this is due to the presence of hyperbilirubinuria. The stools, on the other hand, are also affected because there's no stercobilinogen, so the stools become acholic and pale in color. So in summary, obstructive jaundice, there is jaundice which is due to hyperbilirubinemia, conjugated bilirubinemia. There's dark urine which is due to hyperbilirubinuria, and pale stools due to lack of stercobilinogen. Next, we come to the classification of jaundice. Jaundice is classified into three categories. The first is called hemolytic jaundice, which is due to overproduction of bilirubin. There is excessive of hemolysis of the RBC in the blood, which results in increased unconjugated bilirubin in the serum. The second category is called hepatic jaundice. It is where there is impaired liver function, where the hepatocellular dysfunction in the liver is unable to handle the bilirubin uptake, metabolism, and excretion of bilirubin. So in this type of jaundice, both types of bilirubin, conjugated as well as unconjugated, are elevated. In the third category is called obstructive or surgical jaundice. Okay, this is due to the obstruction of bile flow from the liver into the intestine. There are two types of such obstruction. One is called the intrahepatic cholestasis, where the obstruction is within the liver, and the second is the extrahepatic obstruction, which is outside the liver. And this is classically called the surgical jaundice. In this type of jaundice, there is marked elevation of conjugated bilirubin in the serum. Next, we come to the causes of obstructive jaundice. These can be classified under three categories. First, intramural or intraluminal causes, that is within the bile ducts. The most common is choledocholithiasis, or the presence of gallstones, within the bile duct. This is the most common cause. Others will be foreign bodies, especially the presence of parasites, okay, which used to be a common cause. Presence of Ascaris lumbricoides used to be a common cause of obstruction of the bile duct in children, but nowadays it has become very much rarer. The second category is intramural causes. That means from the wall of the bile ducts, and among them will be the benign and malignant strictures. Okay, benign strictures are more common, usually due to the passage of stones, previous history of gallstones, due to iatrogenic causes such as ESCP procedures, which is becoming increasingly common these days, and sclerosing cholangitis, which is a congenital condition. The malignant strictures will be cholangiocarcinoma, which is a rare cancer but is a common cause for strictures in the malignant category. The third group of causes will be the extrinsic causes coming from outside the bile ducts. This is usually due to pressure from outside, such as carcinoma head of the pancreas, periampullary carcinomas, and important lymph nodes, especially in the portal and hilar lymph nodes, which can cause pressure on the bile duct and cause jaundice. The other important cause is accidental injury or ligation of the bile ducts during surgery. Okay, this diagram here simplifies the causes of the various causes that can result in obstructive jaundice.
What are the consequences of bile duct obstruction? Okay, this is the process or the progression of the obstruction that takes place in the bile duct. First, there is the obstruction by, for example, a stone. There's obstruction of the duct, followed by dilatation of the proximal segment of the bile duct, leading to stasis of bile within it, and this leads to colonization by bacteria, and that predisposes the patient to septicemia, bacteremia and septicemia. Some of the complications of this obstruction. First, infection. The most severe or most serious form of complication is infection and cholangitis, and this is especially so in patients with gram-negative infection, leading to early sepsis and septicemic shock. Second, jaundice. Okay, the staining of the tissues with bile pigment. Third, secondary liver damage due to chronic obstruction, leading to fibrosis and cirrhosis of the liver and even lead to liver failure. Fourth consequence is bile deficiency in the gut. This is due to the bile unable to reach the gut due to the obstruction. As a result, there is fat and fat-soluble vitamin malabsorption, leading to steatorrhea and vitamin deficiency, especially vitamin K, which leads to coagulopathy.
The clinical presentation of bile duct obstruction. Although the symptoms and signs may vary from case to case according to the cause of the obstruction, in general, the symptoms are abdominal pain, typically at the right upper quadrant, jaundice, which is usually gross, and fever, characterized by chills and dry gauze. These three features collectively will be known as the Charcot's triad, which is a common occurrence in patients with ascending cholangitis, which is a complication of bile duct obstruction. The other features are dark-colored urine, pale stools, easy bleeding or bruising, generalized itchiness of the skin or pruritus, loss of appetite, and general feeling of sickness, malaise, or lethargy. The complications of bile duct obstruction. Ascending cholangitis is a serious complication of bile duct obstruction. It can bring about early septicemia, liver abscess, and even acute liver failure. Liver injury due to cholestasis can result in cirrhosis of the liver, liver abscess, and chronic renal failure. Bleeding tendencies is another important complication due to the lack of vitamin K. Hepatorenal syndrome is another important complication which can lead to acute renal failure. Infections of various kinds, especially gram-negative infections, are common in patients with liver failure and obstructive jaundice. Nutritional defects or deficiencies are important complications due to the lack of bile in the intestine. Of importance is the fat and fat vitamin, soluble vitamins that are not absorbed due to the lack of bile.
Okay, besides the cholelithiasis, what are the other common causes of obstructive jaundice? Okay, this can also be due to carcinoma ahead of the pancreas, Peri carcinoma, carcinoma of the bile ducts or cholangiocarcinoma, biliary strictures, and especially due to iatrogenic causes and sclerosing cholangitis, and intrahepatic cholestasis from drugs also can lead to obstructive jaundice. Okay, next we come to CBD stones or cholelithiasis. Okay, CBD stones are not very common. They are present in about 10 to 20% of patients with symptomatic gallstones. It most commonly results from the passage of gallstones through the cystic duct. So the stones are primarily formed in the gallbladder, 90% of them. And these stones migrate up through the cystic duct into the bile ducts, where most of them get impacted at the lower end of the CBD or the ampulla. Only 10% of stones are primarily formed in the bile ducts, and these are usually pigment stones. Complications of bile duct stones, the most important complication is biliary obstruction with cholangitis, usually also known as ascending cholangitis, which can lead to early septicemia and septicemic shock. Other complications include pancreatitis and chronic obstruction due to biliary obstruction. This slide shows you some images of CBD stone or choledocholithiasis. So this is the first one is your ultrasound findings, okay, which is shown in colored codes. This is the liver, this is the pancreas, and this is the bile duct. Okay, this is the bile duct, and there is a stone here, filling defect at the lower end of the bile duct. So this is choledocholithiasis on ultrasound. This is a CT scan finding showing you the lower end of the CBD is dilated and is occupied by or filled with a stone. Okay, and the gallbladder is also distended slightly. Okay, this is another one CT scan finding of choledocholithiasis. These are more images of a bile duct stone. This is a ERCP film showing you a dilated CBD with a filling defect. There are two filling defects suggestive of stones in the lower end of the CBD. And this is a pancreatic duct. This is the EUSS or endoscopic ultrasound picture showing you a dilated CBD with a stone at the lower end. This is a MRCP film showing you gallstones as well as stones in the CBD.
Mirizi syndrome. This is defined as common hepatic duct obstruction caused by extrinsic compression from an impacted stone in the cystic duct or infundibulum of the gallbladder. Okay, here is a stone impacted in the cystic duct, or it can be also be the infundibulum, and this causes common hepatic duct obstruction. Okay, this is due to the chronic infection, fibrosis, and also edema that causes pressure onto the common hepatic duct and causes obstruction. Thereby, the bile ducts proximal to it becomes dilated, with the bile becoming stasis and predisposes to obstructive jaundice and infection. This diagram shows how carcinoma of the head of the pancreas can cause obstructive jaundice. Okay, this is the pancreas, and this is the head of the pancreas where the tumor is located. Go. This tumor presses on the lower end of the bile duct that traverses the head of the pancreas, and because of its proximity to the pancreatic tissues, any tumor here will easily causes early obstruction and jaundice. Okay. This jaundice causes obstruction causes stasis of bile in the proximal ducts and also the cystic duct. So the proximal ducts are dilated, including the intrahepatic ducts, causing intrahepatic stasis of bile as well. The stasis extends, or blockage or the pressure extends down to the cystic duct and into the gallbladder, and that causes a dilated gallbladder. Okay, so classically, head of the pancreas, cancer of the head of the pancreas causes obstructive jaundice and a clinically palpable gallbladder, which is in keeping with Courvoisier's law. So a word about carcinoma of the head of the pancreas. Carcinoma of the head of the pancreas can obstruct the bile duct and often present as painless obstructive jaundice. Okay, I emphasize the word painless here because classically the jaundice caused by carcinoma head of the pancreas is painless. Courvoisier's law defines that the presence of jaundice and a painlessly distended gallbladder, strongly indicative of pancreatic cancer, and may be used to distinguish pancreatic cancer from gallstones. The risk factors for this cancer are smoking, alcohol, diabetics, males, age over 60 years. This is a CT scan image demonstrating significant bile duct obstruction in a patient with CA head of pancreas. Okay, the radio-opaque mass here and a radiolucent central region. This radiolucent area is the bile duct, which is distended, surrounded by pancreatic cancer tissue in the head of the pancreas. The other significant change here is a very grossly distended gallbladder. Gallbladder of this distension will most probably be palpable clinically as well. This is a picture to show cholangiocarcinoma. After the CA head of the pancreas, the cholangiocarcinoma is another common cause of bile duct tumors obstruction and causing obstructive jaundice. Cholangiocarcinoma can occur in the intrahepatic ducts or in the extrahepatic ducts. And the most common site is the hilum of the liver, where the tumors known as Claskin tumors. Okay, so these tumors produce marked strictures of the bile duct with gross jaundice, which is usually very progressive and deadly. This is another CT scan on the left side here. It shows a mass here, mass lesion, radio-opaque mass lesion, which corresponds to the head of the pancreas. So it's carcinoma head of the pancreas, okay, which causes obstruction of the common bile duct, which has become very grossly distended. So is the gallbladder, which is also grossly distended. Okay, this is a picture which confirms mass of the head of the neck of the pancreas causing obstructive jaundice. In this X-ray, which is a ERCP film, it shows intramural lesion. Okay, intramural lesion rising from the common bile duct, and this is a case of cholangiocarcinoma, where the dye is injected and then there is marked narrowing, irregular narrowing, filling defect. So this is a cholangiocarcinoma of the lower CBD. Here you can see the proximal CBD is very markedly dilated, which is due to the obstruction. The next cause of obstructive jaundice is periampullary carcinoma, which occurs around the ampulla of water. Okay, this is the ampulla of water formed by the confluence of the pancreatic duct and the bile duct. Okay, just before it enters the second part of the duodenum. So adenocarcinoma arising from these structures around here, which consists of carcinoma of the ampulla, carcinoma of the surrounding duodenum, and or carcinoma of the lower end of the CBD. These three are collectively known as the periampullary carcinoma because it's difficult to differentiate one from the other even by histologically. The important thing is it can cause very serious gross jaundice, which can rapidly cause deterioration of liver function and death. Periampullary carcinoma has got a very poor prognosis.
This slide summarizes the various investigations that are usually done in a patient with obstructive jaundice. blood tests, especially the liver function test, ultrasound scan, CT scan, ERCP and brushings, MRCP and EUSS plus FNAC or biopsy.
The blood investigation in obstructive jaundice is basically liver function test. Serum conjugated bilirubin is markedly elevated in obstructive jaundice. In fact, the direct bilirubin is usually more than 50% of the total bilirubin, and this suggests post-hepatic rather than a hepatic obstruction. The alkaline phosphatase, the enzyme from the liver that is excreted into the jejunum, is blocked. As such, its level in serum becomes markedly elevated. The liver transaminases are usually normal or slight to moderately elevated. Fecal urobilinogen is decreased in incomplete obstruction and absent in complete obstruction, leading to pale stools. The urobilinogen in urine is absent in complete obstructive jaundice, with increased conjugated bilirubin in the urine, and this is known as bilirubinuria. This chart summarizes what I've just mentioned. Unconjugated bilirubin is normal in obstructive jaundice. Conjugated bilirubin is increased. Alkaline phosphatase is markedly increased, very high in obstructive jaundice. The urine bile salt is present in obstructive jaundice. Urine conjugated bilirubin is present, causing urobilinuria. Urine bilinogens, which is the urobilinogen in urine, is absent, nil. Fecal urobilinogen is also absent. Okay, this is an ultrasound scan picture of a patient with obstructive jaundice. In this patient, here you see a dilated bile duct with a gallstone at that lower end, which casts a posterior acoustic shadow, which more or less confirms it is a stone. The portal vein lies posteriorly, it is normal. The rest of the liver tissue is normal. So this is a case of a choledocholidiasis with obstructive jaundice. Endoscopic ultrasound, or EUSS, is very useful for patients with obstructive jaundice. It is particularly useful in patients with pancreatico-biliary pathologies. In fact, it is 98% diagnostic accuracy in patients with obstructive jaundice. It allows diagnostic tissue sampling via the endoscopic ultrasound guided fine needle aspiration, a form of FNAC. Its sensitivity for focal pancreatic masses has been reported to be superior to CT scanning, particularly for tumors less than 3 centimeters in diameter. Compared to MRCP, diagnosis of biliary stricture, EUSS has been reported to be more specific, almost 100% versus 76%. So, in places where EUSS is available, this is a very useful investigation which could be done for jaundice patients. Okay, what are the treatment options available for obstructive jaundice? Number of treatment options are all listed down here. Antibiotic therapy, will be indicated for infection, adequate hydration through IV fluids, pain medication and nutritional support if necessary, ERCP, biopsy, stone removal, dilatation and stent replacements. These are all can be done with the use of ERCP. Surgery, curative resection or palliative bypass. And when applicable, adjuvant therapy for cancer includes chemotherapy or radiotherapy. In general, tumors causing obstructive jaundice, the prognosis is not so bright, whereas obstructive jaundice, in the vast majority of cases due to stones, they have good prognosis, which can be treated with curative surgery through endoscopy or open surgery. Surgery in obstructive jaundice can be classified as curative surgery or palliative surgery. Under the curative surgery, the most commonly done today is endoscopic sphincterotomy and extraction of stone at the lower end of the CBD. This is done via ERCP. If this fails, then patient can be subjected to an open procedure, cholecystectomy and removal of stone from the CBD. In patients where the stone is impacted at the lower end of the CBD and unable to retrieve from above, a cholecystectomy, that is a bypass between the dilated proximal CBD with the duodenum beside it. This offers a reasonably good operation for draining the CBD. Then the People's triple surgery or triple resection is a very major operation, which can be used as a curative surgery for patients with early carcinoma of the head of the pancreas, as well as periampullary tumors. Under palliative surgery, again, the first choice is still endoscopic procedures through ERCP, intubation of the blocked tube, CBD, and stenting of the CBD. In patients with not suitable for such stenting or endoscopic procedures, cholecystectomy can be done. A simple procedure of introducing a catheter percutaneously into the distended gallbladder to drain out the obstructed biliary system. For more definitive procedure, you can do a cholecystogeginostomy, where the gallbladder, which is grossly distended, is anastomosed to the jejunum, thereby providing an alternate path for the draining of bile from the obstructed system into the jejunum. Okay, this picture shows you the technique of ERCP sphincterotomy and stone extraction. Okay, this is the ERCP scope, the side viewing camera, and a catheter is introduced. The catheter with a bulb balloon at the tip, which can be distended. A sphincterotom comes from applied to do a sphincterotomy, cut the sphincter to widen the passage, thereby making it easier for the extraction of the stone. So as the catheter is withdrawn, the balloon from here will pull the stone together and bring it out into the duodenum. That is known as a ERCP sphincterotomy and stone extraction. Okay, this picture shows the widely used Whipple's procedure, Whipple's triplet operation. Okay, this is before. Okay, there's a cancer in the head of the pancreas, tumor in the pancreas causing obstructive jaundice. So the distal end of the stomach, the head of the pancreas, and the duodenum, they are all removed. Gastro-pancreaticoduodenectomy. Okay, that is the procedure that is done, triple operation. After the operation, these are the three bypasses that are done. First, it's known as the cholecystectomy. Okay, the common hepatic artery is anastomosed with the loop of jejunum. And this loop is also anastomosed to the transected end of the body of the pancreas. And that is known as the pancreaticoduodenostomy. And the third bypass is between the stomach, whose distal end has been removed, is anastomosed also to a loop of the same loop of jejunum. And this is known as gastrojejunostomy. This is a clearer diagrammatic representation of the Whipple's operation. Okay, here the first bypass known as choledochojejunostomy, the second bypass known as the pancreaticojejunostomy, and the third bypass is the gastrojejunostomy. So you can see here is a very major operation, and not many of these patients with severe obstructive jaundice, especially with malignant lesions, are fit for such an operation. For patients who are not fit for Whipple's operation, a lesser palliative procedure can be done to decompress the dilated and distended biliary system here, okay, including the liver. The gallbladder very grossly distended. As I said, a tube can be placed, indwelling catheter can be placed into the percutaneously into the gallbladder to drain the bile out. Thereby, it decompresses the whole system, and the jaundice will reduce. A better procedure is to join the distended gallbladder to the adjacent duodenum here. Okay, that is known as the cholecystoduodenostomy. But a better procedure for long-term symptom-free is joining the distended gallbladder to the side of the loop of the jejunum. So this loop of jejunum is brought out, and then this is anastomosia. And this is known as the cholecystojejunostomy, which offers very good relief. Procedure is a minor procedure which can be done laparoscopically or open method, and is very rapidly decompresses the biliary system, and patient feels better. Now, for patients with obstructive jaundice who are subjected to such operations, there are very special risks that must be addressed in the preoperative preparation for this operation. What are these risks? Usually these patients are in poor nutritional status because of the severe malabsorption and steatorrhea due to the lack of bile. So they have to be given some form of enteral or parenteral nutrition before they go for the surgery. Due to vitamin K deficiency, the patient will have some form of coagulative problem, okay, coagulopathy, and this has to be addressed, must be treated. Otherwise, you will have troublesome or serious intra-op or post-op bleeding. This can be done by preoperative vitamin K injections. Jaundice patients, especially obstructive jaundice patients, are prone to infection and they must be covered with adequate antibiotics, especially to prevent gram-negative septicemia, which is quite deadly in these patients. Wound healing is a problem too in these patients with severe obstructive jaundice. And their reduced liver function tests, especially albumin, will be a cause of wound infection and wound breakdown after the surgery, especially open laparotomies. So, to avoid this, the patient should be given adequate transfusion of human albumin or fresh plasma prior to surgery. Hydration is another problem with patients with deep jaundice. They are usually poorly hydrated, and this poor hydration can lead to hepatorenal syndrome and acute renal failure in the immediate post-op period. So these patients must be adequately hydrated with IV fluids, and strict IO chart should be maintained, and if necessary, a central venous pressure monitoring should also be undertaken prior to surgery to ensure adequate or ideal hydration status. Finally, this is the flowchart which summarizes the treatment of obstructive jaundice. Okay, patient comes with obstructive jaundice, which has been confirmed with blood tests, especially elevated conjugated bilirubin. Ultrasound of the common bile duct should be done, including the gallbladder. In fact, ultrasound of the gallbladder and biliary tract must be done. If the CBD is dilated and gallstones are present in the CBD, then an ERCP plus sphincterotomy and stone extraction should be done, followed, if the conditions permit, for a leg cholecystectomy laparoscopically. If the CBD is dilated but no stones are seen, then you have to look for other causes of the CBD dilatation, which will need an ERCP or MRCP and even a CT scan. This is to mainly to rule out Peri and pleural neoplasms, Cholangiocarcinomas, or other forms of tumors. In cases where the ultrasound of the biliary tract is normal or there's no other detectable cause, then you go for a CT scan and ERCP and treat the causes respectively. If, for example, if you find a stricture, then ERCP with stenting may have to be considered.
Thank you for your patience.